Okay. Now, we thought it'd be very helpful to have feedback, and we thought we should ask a surgeon for feedback first. So, Mr. Scott.
It's funny you should say that, because
you don't do ward rounds?
No, what we thought was what we thought was something we don't have in surgery, which is lots of time. As physicians have lots of time for their
Okay. But in the unlikely event of you seeing a patient, taking a history and examining them in front of other people, tell us about ward rounds.
Right. What our training thought was really important, that it was a non-threatening environment.
Yep.
It should have good quality information.
Yep.
And that it should be a very open environment. Okay. And what we then started talking about was how we kept the junior doctors or trainees engaged in ward rounds.
Okay, so keeping them
because you can
feeling
have
part
these very long physicianally ward rounds.
Okay. Right, we need a physician to redress the balance. Jeff's a physicianally A&E.
I don't do a lot of ward rounds.
But using your expertise.
Lynn started by saying her perception, having never been on a ward round, is of where juniors present what they've done, and then I tell them whether they're right or wrong. And I said, well, maybe. But what I also do is and it may be me, I don't know if other people do it, in my specialty, is review what's happened to the patient right from the very beginning to where they are now. I find that incredibly useful exercise.
Yeah.
And because I don't want them to get the impression that what's happened to this patient is necessarily appropriate. So where it's inappropriate, I want to say that isn't really a very good thing to have done. We could have managed, the health community could have managed this problem in a much better way. Okay. Which was one other thing. There was one other thing we talked about, which was asking embarrassing questions that you know that a junior doesn't know the answer to, for the simple purpose of getting them to think that it's okay to ask these questions. Right. Because they should be asked the challenging questions. We need to find out what the answers are.
So you ask them questions, and you want them to ask you questions.
Both, yes.
Okay, great. Any other points?
I think we're using S-bar for presentation. So now, when they hand over in the morning, when they come, that senior house officer at night time, we have to present information.
Okay.
I have to use S-bar.
So a structured way of getting the information. Yeah, good. Any other points that make it a good teaching round? That's what we want.
I wonder if it's worth asking the learners what they would like to get out of it before you start.
Okay.
Because it's extraordinary how often there are opportunities to focus on those things.
Yeah. Good.
I was obviously there's two types of ward rounds. In some cases teaching, and then one's the ward round where you've actually got to achieve things for the patient. So when I'm to you, that's where I do my ward rounds. We've got it has to serve both functions, and that has to be divided up. And we've struggled over the years to try and get it's a changing process all the time. So our handover has to be very good. It has to be a timed handover and chaired for half an hour. So and the different chairs, different levels, multidisciplinary, and they have to decide what information has to be handed over and what information has to be worked out.
Okay, so it's time management, being concise, knowing what you need to do.
Yeah.
I think the concept of teaching and non-teaching ward rounds sometimes helpful, but I think it's best to assume that whenever you're doing anything, you're teaching. People may not realise that, but you are. Any other burning points?
Could be covering anything, or not, and it could be very general. But should you agree some domains that particular round is going to cover? So you focus on an area of the curriculum or good medical practice or something.
Okay. So setting out in advance what you're going to do.
It's a bit about having time, but we said trainee led.
Yeah.
Training like that. Possibility of doing workplace assessments.
Yeah.
One-stop ward rounds where you sort of do the job as you go along.
Yeah.
Having a control available helps the task.
Always revolutionise ward rounds. Right. Any?
And then rounding up the ward round with what we call the 3-minute ward round.
Right.
So where you just pick up the learning points which you have already picked up, doing all the things that we have already
at the end of the ward round.
At the end of the ward round, and then going over.
So that people know what they've got out of it. Okay. So I did some work. I've done some work asking trainees what they thought worked well, and just a 2-minute distillation for that. So yeah, agree how much time you've got, Big difference if it's half an hour or a physician is 3 hours. So the surgical 10 minutes or the medical 120 minutes. Be on time, don't keep people waiting. Explain what you're doing. Most medical students, up until recently, have never actually had explained to them what ward rounds are all about, what to do, how to get the best out of it, what the whole point of it is. Medical schools are definitely much more engaged in teaching that now. Keep people on the round for at least half an hour or an hour. So again, it's don't let the trainees drift away. Because I start off, and I don't think it's just me, says he paranoidly, start off with 4 people, and within 5 minutes, only 1 person. Now, honestly, it's not because I'm chronic teaching, I don't think. It's because they get distracted, they get bleeps, phone calls, text messages, things to fill in, discharge letters. So keep people for at least half an hour to an hour. Say at the start, please do not go away. Stay with me for at least half an hour, because you will benefit from this, and the patients benefit, which of course is the key thing. Get them to present a few patients, yeah, definitely, and questions 2 ways. Ask them questions, get them to ask you questions. Why are you doing X and not Y? Because sometimes there isn't a good reason. Be really revolutionary. This is for the surgeons. Retake the patient and even examine the patient. Okay, so consultants sometimes examine a patient on a ward round. It's really neat. The trainees like to see you doing that, seeing how to examine a particular lump. Be involved. Give feedback and think out loud. In other words, if you're not sure what's going on, or if you are sure, if I've anguished for 5 minutes, 2 minutes on some funny chest pain, it's because I'm anxious it might be aortic dissection. Meanwhile, the trainees are thinking, why is he spending 2 minutes on this umbius musculoskeletal pain? It's because I need to make sure it isn't a dissection, because the consequences are dire if I miss it. So think out loud, that's why I'm anguishing, because I'm worried about this or that. And then the trainees understand what you're doing. It makes a huge difference. And then the final couple of things, try and take the all-rounded view, be holistic, because most patients that we see are frail, multiple problems and so on, so you need to take a wider view. Realise that you're a role model. You can choose the role model you want to be. So obviously not the one that most physicians would choose to be. They might secretly choose to be like that, but in real life, you can't be like that. You've got to be real. You've got to be compassionate and take the wider view. Of course you have. So the rheumatologist in my place who kneels down and holds the patient's hand, fantastic feedback that he gets for the way he deals with patients. And have a few minutes at the start at the end to go through the notes with a cup of coffee, going through the list of patients you've seen or you're about to see, look at the x-rays, discuss what you're doing. It's a really efficient way of dealing with a large number of patients. And it's good fun. The whole thing is enjoyable. You can turn it around from a drudge into something that's good fun and everybody enjoys and learns from. So that's the start of what we're going to do, the start of the journey, which Dr. Caldwell will now take forward.
I think what you covered there is a lot similar to what was said in the previous workshop, which is about creating the physical and cultural environment where it's all right to talk and ask questions and to talk out loud about what's going on and to show your ignorance. I think the bit about access to information is crucial now. I was really surprised to find that our 5th-year medical student last week was doing the national exam for prescribing and is not allowed to have her smartphone in the exam. I think my juniors are at the bedside without their smartphone, without the EBNF on it, they are being negligent. So why on earth are we teaching them that memory is a good way to do it? Access the information. Yesterday on the ward round, woman with severe thrombocytopenia, platelet count of 12, we learned that telmisartan can cause thrombocytopenia. We learned that within 25 seconds by using hippocrates.com. Free American database with all the side effects of drugs, very accessible. What else did we learn yesterday in the ward round? Shoshin beriberi, anybody ever heard of it? Form of beriberi thiamine deficiency, which presents with a person looking as if they're in cardiogenic shock, not cardiac failure. We found that because we thought that our patient might have beriberi because he was an alcoholic and he was in shock. We'd never heard of that. We found that within a minute from reading Hippocrates. That's how the information should be there. We should be learning there and then as much as possible. So very similar stuff to what was covered before, making everybody have a role in the team. Right, swap over. Can I ask you to move, because I assume we're being broadcast for Louis Theroux's next programme. How many people here are not doctors or nurses? Right, a lot of you, good. Hopefully you're all very well, and I'll try and talk about being ill in very simple terms, because this ties in with the central importance of ward rounds. in my way of thinking, people are either well, acutely ill, critically ill, or dead. And the wonder of modern medicine is that people can move from this trajectory, which was severe acute pneumonia in a young person, to death in 48 hours.
Where's chronically ill?
Oh, we'll get to that later. So people used to die of pneumococcal pneumonia. They used to die very quickly of pneumococcal pneumonia until Fleming discovered penicillin, and we can now give them the penicillin and they get better. So this is the trajectory of a young person with a nasty pneumonia who becomes ill, put a treatment in after diagnosis and gets better. If you don't give the treatment, like somebody said the ticoplanin hadn't been given, they can shoot off down there very rapidly. More commonly, our patients now, as you say, David, have got multiple comorbidities, maybe elderly, maybe young with other health problems. They start off at slightly less well, become ill, we make a diagnosis, we consider the comorbidities, we give some treatments, and they sort of slowly get better. Or they may hold on at this level for a while before something horrible happens, or they may drift down, and then we realise that they drift down, recognise the deterioration, rescue the day, and bring them back up again. This bit, the sort of diagnosis and early treatment, happens in accident and emergency or in our assessment units. This bit is the person making the right progress, happens on our general wards. And this is what we're talking about here is the ward round. So what you're trying to do on day 2, perhaps, is work out whether the person's here, here, or here. And you have to ask different questions and different approach to treatment at that stage, depending on whether you think they've got better, staying the same, or getting worse. And these ones are really difficult to pick up. The person who's been in hospital 7 days and is just slowly drifting off, and then suddenly something happens. There are some other patterns or trajectories of illness. The patient can come in with gallbladder problem, have the gallbladder taken out by the surgeon, they start to get better, and on day 5 have a coronary thrombosis or a pulmonary embolism and drop dead. This one is what cardiologists are all about. The patient has an acute myocardial infarction, develops ventricular fibrillation, so they're dead. They apply the electric shocks. 5 seconds later, the patient is well again, makes a fantastic recovery, and because they've been under cardiology, they're actually even better than they were when they came. And this patient is one we increasingly see, all of us see in hospital now, is the chronically debilitated, very frail, multiple comorbidities patients, usually very elderly, or sometimes they're patients with advanced cancer or multiple sclerosis, cerebral palsy, who come in really very low on this sort of general health scale and deteriorate, and you hope you can get them back somewhere near to their baseline. Again, on every ward round, you're trying to work out, has the person progressed according to trajectory? So that's what ward rounds are about, and I don't think we often explain that very well. We're trying to find out, is the patient getting better? Are they deteriorating? Even if they're getting better, have we still got the diagnosis right? Because sometimes you can have given an antibiotic for pneumonia, which works for a urinary infection, and you might fail to diagnose their bladder cancer because you've got better and you thought it was pneumonia. So that's what ward rounds, I think, are all about. Now, I didn't talk very much about role modelling and changing roles on ward rounds. A lot of us get our registrar, for example, to do the bedside review, and we're there in a supervisory role. And my year 1 doctor one time did the whole ward round, did all the consultations with the patients, made all the decisions and everything with our support. At the end, she said it was good, it was very rewarding experience. She'd actually been brilliant with the patients, lovely in her approach to the patients, but she said, I don't know whether we've done it all. And that was on a Monday. By Friday, we'd completely changed our ward round practice because I said to them, go away and come back to me on Wednesday with what you think, a list of what you think doing it all is on a ward round. I'll think of myself for those 2 days. We'll meet Wednesday lunchtime and we'll decide what doing it all is on a ward round. So now, in your groups of 2, the people you know so well now, 5 to 10 minutes discussion on what you think doing it all on a ward round is. You might have headings or you might have a huge list. Go.
I think yeah, that
I cut the patient's side out? Did I do the right test? Have I got the results here? Did I act on them properly? Did I write the protocol up? Have I talked to the or if it's petrol, are they going to rather than listening and learning, will be busily writing the drug charter or the letter, the discharge letter. So there are all these things that can start to make you more efficient, which you have to learn. Which is nothing to do with training.
Yeah, a huge amount that comes from the experience of what might happen in the long run and some of the complications, side effects, which you could anticipate and try and predict.
And that is the main point about because they're well
Good to hear you all talking like that. Hopefully it's not as it's a Grand National or something. Graeme would now like to take some ideas from you, so we will just go for it, and whoever wants to shout out is the person who will be listened to. It was the Grand National. Nice.
Yeah, I get that, yeah. We thought reflection and feedback would be quite important. So reflection from, say, for example, if a trainee led the board round, then at the end of the board round, you could ask them for themselves what they felt went well, what didn't go that well, or and what did they learn from the board round. So that would enhance
Very
their
good.
learning.
So when part of doing it all for a board round is a debriefing session at the end with some feedback. Excellent. I'm going to have to start asking people.
We kind of went for a pre-briefing, and we thought that actually the notes straight sit in front of the computer with a cup of coffee and talk to all the patients and have a really clear understanding of where you got to with each one of them was really helpful. Different people could lead on that. We felt it needed to be multidisciplinary. We felt that helped to synthesize what the issues, the biomedical issues and options were, and then when we would take that with us, in our hands to the bed and begin to understand what the patient knew, believed, was concerned about, thought, so we could then begin on the ward round to put those two together.
I like that. I think the Americans call that a table round. From what I understand, it seems quite a good phrase for it. Yeah, ideally multidisciplinary, and if you've got good technology, you should be able to take your synthesis with you to the bedside on the computer. Would be the ideal thing. Yeah. Excellent. So we've got an ending bit, we've got a preparatory bit, and I think what you're talking about there is reviewing the security of the diagnosis, reviewing, seeing if there's anything that's outstanding that doesn't fit. I don't know, treatment for pneumonia and the sodium's 106, which is really low, so have they got lung cancer as well, that sort of thing, as well as the how's the patient going to go home, what's their emotions like, have they fallen over and fractured their hip, that sort of stuff. So pre-round briefing. What about when we get to the bedside? What's doing it all at the bedside?
So bringing yourself up to date with all the information that we have, as you said right at the beginning, then track the patient journey with all the information that we have, making clinical judgments, because that's the purpose of your presence there, the senior clinicians. And then we were just talking about implementing the Chinese takeaway method for each of the.
Okay, so you're talking about
make decisions and then make sure it's understood and transmitted.
So Americans didn't have all the phraseology for this. That's read back.
Yeah.
The ultimate read back will be when our patients read it back to us. You've told me I've got pneumonia, I've got COPD, you've told me you're worried about lung cancer, you're going to do a CT scan, and I'm going to be home in 2 days' time and follow up in respiratory clinic. That would be the ultimate, yeah? David?
I thought the point of this, with the trainee saying that, was had I done the right things, had I ordered the right test, did I have the right results at my fingertips, were the x-rays there, had the other consultant come to do the visit that we said we would arrange, had I talked to the relatives, have I already written the discharge summary and the TTOs, and how am I doing that while you're talking to the patient I'm supposed to be learning from you?
Excellent. So David's given us another big list of things that need to be done on the ward round. Anybody take it from the point of view of the patient? If you're the patient lying there, what do you think should be done for you, with you?
Communication and not being talked over.
Yeah.
And being included.
So as a patient you want communication clearly with you. Have you anybody here been a patient?
Many times.
Yeah. So how often do doctors tell you that they're talking to you and then that they're doing doctory talk?
Too much doctory talk probably. And I've worked in hospitals years, I understand more of it than your average patient would.
Tony Miles is one of our surgeons. He teaches the doctor who's doing the consultation, saying, you're 5 days after your cholecystectomy, you're making good progress, we are worried you've got a deep vein thrombosis. I'm now going to do some doctory talk. You can go to sleep, and we'll tell you at the end of the consultation what the conclusion is, and then turns away. And that just takes all the pressure out of the patient, doesn't think, I've got to listen to all this D-dimer and stuff like that. So communication with the patient, yeah? Relatives,
or arrangements.
Okay, so communication with the relatives. Big project Wexham Park, I think, at the moment, to get patients there on the relatives there on the ward round, which is where they should be.
Continuity of care.
Continuity of care. Yeah. So arrange continuity of care. That might be to do with were you thinking night shift, weekends, handovers, that sort of thing? Yeah. So we've got a big problem with continuity of care.
And just linked to that, I'm, as an administrator, quite concerned about it all being appropriately documented into systems so that they don't get lost.
Communicating with the nursing staff doesn't always happen. It should.
Tell me about what you think should happen then in the communication. What you wanted the nurse there at the beginning before you headed off on the round. What do you want to happen at the bedside?
I would, I think that's what I really want to get in.
But when my registrars leave the ward round, the nurse turns up, she hangs around at the back of the bay, putting her head through the curtains, and they ignore her completely. She's there. Is that what you want?
No.
What do you want the nurse to tell you?
I think they've got important information.
Yeah.
I think they should contribute.
So you want, on the ward round, somebody to listen to the nurse?
Yeah.
Good.
Presumably they've done obs and can feedback what's happened overnight, deterioration, that they've been sick 5 times, like, you know.
So part of doing it all is listening to the nurses.
It's true as well.
Yeah.
So, I mean, I agree with David. From what, I think all our views are very similar on what the ward round what doing it all means. It's just that you see it from different perspectives. The trainee's got to see all the jobs as well as learning.
Yeah.
But essentially what you're doing is integrating your clinical physiology that you're finding to their current medical problem as well, and their functional capacity. So you've got to get their social history. And then the other side of it is communicating it to the patient, and then communicating what you've got to offer with all that sort of tied in. And you have to then try and tell them where they are in that process as well, and the trainee as well, where they are in that process. So for that point in time, they've done it all, or this is what needs to be done, in which case you then have to communicate that to the relevant staff and the relevant doctor who's going to take over.
So you work in intensive care?
Yeah.
What's the
We're
point? Tell me what the point of the care bundles is in intensive care.
To deliver the right treatment to the patient at that time, and bringing all the teams together to do it.
So there's a care bundle for making sure the patient
Yeah.
doesn't get a ventilation-associated pneumonia,
Yeah.
and that's to make sure the patient's sitting in the right position, the ventilator's all switched on properly, they're getting the physio and everything. And that is to prevent avoidable harm, because we haven't heard much on, so far, I haven't heard much from the audience about preventing avoidable harm. So on intensive care, one of the avoidable harms is hospital-acquired pneumonia. What are the avoidable harms that the NHS is so keen on at the moment, and quite appropriately keen on?
Prescribing errors.
Okay, so we got to make, there might be something about VTEs, there might be something about falls. Prescribing errors. Nobody's mentioned it. It's the surgeon's fault. You never look at the drug charts, do you? So you haven't even mentioned that you want anybody to look at the drug chart on the ward round yet.
No, we did. We did.
Good. Speak up with the other bits that you think ought to be done. Yeah.
I think that's making an assessment about the ceiling of treatment, particularly for handover to an important, particularly in care.
Yeah. So ceiling of treatment may be something that's a new concept to you. Instead of saying DNA CPR, which ends up, it's saying if this person who is here becomes even more ill over the weekend, do we send them to intensive care or not? And somebody who's down here, even if you send them to intensive care, won't get better. So you better decide your ceiling of care is ward level care. Because it's not kind to the patient, it's not kind to the patient, it's not kind to the relatives, it's not kind to IT, ITU, it doesn't work. So the ceiling of care would be full ward level care. Or
that's a really important thing on a Friday to determine.
Yeah. So down here the ceiling of care might be go to end of life care if the patient deteriorates.
Can I ask a question, which is at this point, because we're interested in knowing what the patient knows and feels and thinks, you're going to discuss that with the patient.
Okay, so patient understanding, I think that comes under what the technical word, shared mental models. Can we all leave the bedside with exactly the same shared mental models are going on? If you watched Louis Theroux's programme last Sunday, the doctor thought she had told the patient they were dying, the patient thought that her life was going to be saved with the 5th lot of chemotherapy. No sharing of mental models at all. So, shared mental models.
Along the same lines, before we move on to the patient at the bedside, is the patient happy, have you got any questions? Pause for 20 seconds at least. Look at them, they'll be a little bit more interested.
So, giving the patient a chance to ask questions. Right, I think you've covered a whole lot of stuff there. What this shows is that a ward round has now escalated to a new level of complexity, where you cannot rely on memory to do all the jobs. So you've talked about 20 patients at the table round. You've now got 100 different diagnoses, because they've all got 20 main diagnoses and 4 comorbidities. And like me, I got to the bedside and I started talking to the right patient about the wrong diagnosis. Can't rely on memory any longer. It's very complex. There's so many different things to do. You've listed a great number of things that need to be done. It has to be teamwork. And the team will miss things out because it's complex. Just because it's complex. Then the phone's going. Then somebody asks you to come and discharge patients because the bed pressures. Can you write the TTOs? Could you take the call from the GP? Memory is no good any longer. So Kim's game used to be shown 20 objects and then they're taken away and you had to name the 20 objects, or you could take one of the objects away and then you had to work out which object had gone. In my experience on ward rounds, somebody's usually put something vital underneath this box here, hasn't told you it's there, so you don't know it's there to check and it's the one thing that's been taken away. So they didn't tell you they put the patient on gentamicin and you ought to check the gentamicin levels and the next day is death because we've poisoned them with gentamicin. So managing complexity can no longer be done memory, good luck and crossing your fingers. So you've talked about all those things that we might do, and you've got Graeme's, actually he hasn't got a very long list there. Oh, you've flipped over the page, have you? The list is so long. What I now want you to do in your groups is just to think of what your solution would be to managing that complexity. Nobody so far has mentioned checklists, but somehow or other, if you're going to manage that complexity, you're going to have a way that you can know when you walk away from the bedside that you've done all the things that you say have got to be done so that the patient is safe and secure for the next 24 hours. What's your solution going to be? In a group of this size, we ought to come up with about 8 or 10 different possible solutions, designs for checklists, ideas about checklists, talking 2s, 4s for about 3 minutes now. Go.
That's why we have them sitting in a room and the visual
You're working faster than the previous group, which is good. So we've got a few moments. Has anybody got any ideas about how they'd like to organise some form of checklist or completeness checking for the ward round?
We use fast hugs for ITU.
You use
fast hugs.
Fast hugs.
So every
Sounds
time
nice.
you walk away from the patient, there's just a checklist. I mean, that's it's not our model; it's national. So you've got feeding, analgesia, sedation, thromboprophylaxis, H for head up. They have to be 30 degrees. Also prophylaxis. I can't remember G. And S we put on.
Group hugs.
No, it wasn't group hugs. Sorry. No, that comes under ulcer. I just can't remember it. And then, sorry?
Glasgow Commons Guide?
No, no. And the S was we put on for social sepsis to make sure we've done the family chat. And we was just
as well, isn't it?
yeah.
And that's just
can't remember.
Is that a verbal thing, or does somebody actually?
No,
hold it?
it's on our now. It's on our pro forma. And one of the ideas, I mean, all these ideas come, and they're trying to work, and the staff changes, and you're trying to get.
So that's on your pro forma for each patient.
The idea was to get the nurse with the patient at the bedside to go through that checklist with us, so that whatever you've done in the ward round then gets translated, and also that checklist, they have a role in the ward round as well.
It's very good. Midwifery, I think they use something a format called CHAPS or something, I think, which is a very standardised way of communicating, and that's not recorded anywhere. It's just that's the way you talk to each other. Somebody else was talking about SBAR. Any other? So that's a really good solution.
Well, I work in psychiatry, and we have the CPA model, which is the care program approach, which has been in place for years. And at designated points in the patient's admission, we have what we call a CPA review. It has to be multidisciplinary, and there is someone called the care coordinator who is assigned to lead on the care of the individual, who must be present. Their significant other, relatives, loved ones must be present. There must be social services representation. So you have all the disciplines to input into the patient's care. And one of the main focus is planning discharge and thinking about what led to the relapse or whatever, and trying to make sure it doesn't happen again. So you obviously have input from the patient as to what their views are, from their loved ones as to what might be needed to support them, and then from all the professionals who might deliver aspects of the care. So the CPA review is a ward round with a set format,
and
where everybody
is that on a piece of paper, or?
Yes, okay. It's documented, yes.
So that's another solution, well, that's the same sort of solution as yours. For every patient, you have a very set process and you document it as well. And we've got other ideas?
Yeah, we decided that we would break ours down into past, current and future, so that for passing, we thought about looking at what was the history originally on arrival, when investigations of drug trial results, and then now looking at present, what's the new test results, how observations changed, reviewing things like input, output, oral and diary, patient understanding, motive interaction, DT involvement, but also thinking about the future, what's the future care plans, discharge, etc.
So would that be something that was another continuation sheet, or is it?
Yeah, maybe just 3-sided different paper things, but just as a reminder.
So you can see already the different ideas of solutions how you can do this, from the midwifery where they carry a credit card type thing to teach them to talk in the CHAPS format and nothing's documented, right through to a fairly detailed documentation to a structured format. So what you need to do is find a solution that works for your team. You can have a copy of my ward round checklist in a minute. That was the solution that came up with it for our team, and people say, shouldn't that be done in every hospital? No, I think the answer is that it's a complex, difficult situation. You should work as a team to decide what it is you're trying to do, what you think is important to check, and then find some way as a team that you're going to check it. But what's important is that it shouldn't slow the pace of care. When I was developing this checklist, Atul Gawande, who's behind the World Health Organization Operating Theatre Checklist, said to me, don't do anything that slows the pace of care. So it's got 150 checkpoints, which has to be filed in the back of the notes. Having taken the notes to pieces and stuck them in together, you've added 5 or 10 minutes to the ward round. It's useless, it's no good. And this is on old technology called paper, and these things are biro marks, if any of you remember this technology. And you can put it on a clipboard, and you can hand it around, you can drop it, you can spill things on it, and you can fill it in as you go. It's very focused on the doctor's aspects of medical, of the ward round. Right diagnosis, wrong diagnosis, misdiagnosis is right up with drug errors as the leading cause of harm to patients. If we get the wrong diagnosis, give them the wrong treatment, the patient will very likely suffer unless we're very lucky. And misdiagnosis is very common. Right comorbidities, a list of all the other things as well as the thing that the F1 has said is wrong. So the F1 said they vomited blood, but we've added in they've got COPD, type 2 diabetes, renal failure, foot ulcer, and early dementia. Right treatments at the right time, the right place, on the right ward. The evidence from Scotland, I think, is going to show that if you're on the wrong ward, getting team from the wrong care of people, your risk of dying is 1 in 40 just from being on the wrong ward. Right pace, it's got to work with the speed of work. Right to no avoidable harm, make sure you protect the patient from falls, misunderstanding, confusion, anxiety, catheter-associated urine infections, all those things that we know we've got to actively check for. Catheter can be hidden almost anywhere in a patient, in my experience, so you really have to check whether there's a urinary catheter there or not. And better next time, which is what we're talking about now, training. So there should be some training aspect, some reflection at the end of the round. What went well today, what went badly today? I did it really badly yesterday with a patient who I thought knew that they had disseminated cancer. She didn't know that she had disseminated cancer, so I said, you know that you've got disseminated, burst into tears. What did I do wrong there? I forgotten this basic thing. Ask the patient what they understand is wrong with them. Some reflections at them. I'm better next time.
Well, we added right patient on it as well.
Oh, right patient, yes, absolutely. So my thing about talking to the wrong patient, yes.
Does this work for outliers?
Yeah, it's probably even more important for outliers, and I find it even more important when I'm doing the ward round by myself, because it's got so much to do. The chance of missing something is, it works for outliers because they just come as the patient on the, down here, on the 10th patient you see, or the 11th patient you see. I've got a great stack of these in my office from the end of the ward round. So what's the training value of this? The checker is given permission to speak out. So I'd say to a final year medical student or to my F1 doctor, it's your job today to check that we do everything for the patient. It's only once we've done all of that that we can really think we've done everything for the patient. So you're the patient safety officer today, and you're going to tell us if we've missed anything, or even if you think we've missed something. So it's all right to say, I didn't think I saw you check for a cannula, and I can say, yeah, I did, and there isn't one. So it's given them a role. And then at the end of each patient review, before we move off, I say to the person who's checking, have we done everything? And they have to answer yes or no. And if you say no, well, what are the things you didn't do? So I decided I was going to sign the bottom of every notes entry on one ward round. We got to the 5th patient. I said, you've told me I've done everything, but I haven't signed the notes. Oh, I was going to tell you at the end. Well, that's no good. You have to pull out 5 sets of notes and sign them. You've got to tell me now. So the checker learns to be vigilant. What's going on? Is it all being covered? He learns to say, no, we haven't done it all. Have we got that? And the checker learns by doing that what a ward round is. So at Induction on August the 1st, I say, however much David wants you all to have supervised ward rounds, I bet tomorrow your consultant will be on holiday in Ibiza, your SPR will be on a training day, and you'll be doing a ward round by yourself. Answer all those questions. You may not get all the answers right, but at least you've addressed every issue. So they learn how to do a structured ward round. Certainly when my juniors then take over the role of being the person at the bedside, they are doing structured bedside reviews like it took me 20 years to learn how to do. When I introduced my checklist, I used to have one of these on an A4 folder in front of me at the bedside, and it took me about 6 months to get my process down to a regular routine of doing everything and not missing important bits. So they learn how to do a structured review. Does it work? That's much more difficult to prove. I think now there's so many cogs in the machinery of inpatient care that proving that some tiny little cog and that was working nicely has improved the outcome is very difficult. What we've all got to be doing is making sure that our little bits, our cogs, are really clean, well-oiled and functioning properly. It seems outside medicine we're willing to accept that if you're going to get a reliable outcome, you have to have a reliable process. You can never get a reliable outcome if you've got an unreliable process, and yet we let our ward rounds go without any quality control, without any reliability assurance. So I think we're better at our reviews, we're much, much better at checking our drug charts. And this comment at the bottom, we're doing a leadership thing 2 weeks ago. One of our F2s, she plays for a football team. Her coach told her, if you're watching a football match and you don't know which team's going to win, listen, because the team that's silent will lose. And the team where they're talking to each other, communicating, spotting threats, opportunities, covering for each other, will win because they're communicating effectively. And there's definitely much more talking on my ward rounds now. I started this when I saw a ward round with a consultant surgeon taking consent from a patient with 6 students standing around him, all bored stiff. And I thought, look at that resource. We've got to get everybody working, everybody thinking. So I think what we're doing there is training them in the ward round. Thank you. We've got 5 minutes for questions.
That's great. I'm really interested. I know you're going to be doing something with our students in the next few weeks. How do you give the, and I know you probably answered this already, but how do you give the checker value? Because it could be seen, I'm the checker, I'm not really involved, I'm not.
Most of the students are so pleased that somebody's even spoken to them, knows their name and has some interest, at least in what medical school and what their background is. They just flabbergasted already. And they feel it's a very valuable thing. And particularly if they can spot something. Some people say you should miss something out just so the student's got something to pick up on if you want to. But they very quickly engage with it and are enthusiastic for it. And I don't think that's because I'm command and control and you are going to enjoy yourself.
No.
Who was it that you said summarised at the end of your
well,
was it the checklist person?
No, it couldn't be the checklist person because the person who's written the notes. So then if I'm with you and you're the patient, I'll say we've finished the doctory talk bit now, Graeme is going to come and sum up to you. So then I'd stand back and Graeme would come and say, it's day 6 with your pneumonia and your COPD and type 2 diabetes. You're making good progress and we're planning to send you home at 12:30 tomorrow afternoon. Any questions?
Has this prolonged your wardrobes?
Well, interestingly, I never timed them beforehand. I don't think it does. I think actually what it does is enables more time, because everybody knows what the process is, what's going to happen next. I'm sure the ward rounds take the same length of time, but we're doing a whole lot more. I've now got to the stage where the registrar reads out the drug list on every patient on every ward round, and then I say, is the oxygen prescribed? Have we got the indication of duration? Do we need to change the VTE prophylaxis? Now that's moving from times when people didn't even lift up the drug chart. So it's much safer care. David?
Surgeons and anaesthetists to some extent have picked up checklists. Physicians generally haven't. But why do you think that is? You've been talking about this for some years now.
Well, Osler, in one of his quotes, said that physicians, compared with other professions, don't like organisation.
Well, I think he meant physicians, or he meant doctors?
He meant doctors, of course.
Yeah, well,
I don't know why it is. I think we're so uncertain and there's so much grey areas. I think we think you can't apply a process to that, but you can still. So we try and apply a process to an acute coronary syndrome pathway, but we get lost as soon as our patient's got acute coronary syndrome, renal failure, COPD, and we think you can't therefore have a process. But the process is a PDSA cycle for the managers: plan, do, study, act, diagnose, treat, revise, and new plan. In the midst of all that complexity. So there is a process, but selling it to other physicians is very difficult.
But as an anaesthetist, I can say that it took a long time for a lot of surgeons actually to come on board with the WHO checklist, which is done in thesis.
Good ideas sometimes take a very long time to work through in medicine, didn't they? Semmelweis was hounded out of medicine and turned into a madman, because he suggested people should wash their hands after doing a post-mortem before doing an internal examination on the woman who's just had a baby.
I think the biggest pressure,
good ideas don't always take off very quickly.
The biggest pressure on some of our seniors can come from juniors and nursing staff. So if people who are good at it and are enthusiastic about it start doing it, the others ask questions. They say, well, why are you not doing it? Your ward round is different from Dr. X's ward round.
Yeah.
That's really useful.
Well, I always think the popularity of an idea is a poor measure of how good it is. So at the front here we've got bookmark checklists with no ticky boxes for all those doctors who think they don't want to be reduced to tick box medicine. By coincidence, they happen to be exactly the same size of checklists as if you have your own personal Lear jet and you start finding that jet engines are failing. Or you can have the ticky box version. Feel free to come and take them away, and hope you enjoy training your doctors on your future ward rounds. Thank you.